Welcome to the afternoon of the first full day of the 2023 Healthcare Advocate Summit. This particular panel is manufacturer considerations when we look at the idiosyncrasies of different disease areas and patient groups. I'm the moderator, Krista Zodette. I'm the president and chief executive officer of the HealthWell Foundation, and I will allow my panel to introduce themselves. Susanna, if you want to go first.
Sure.
Just make sure you pick up the...
Thank you. I'm Susanna Masardis, and I'm the CEO for the Community Liver Alliance. And the CLA is a national nonprofit organization that focuses on liver diseases.
So I'm not Erin Atkins. I'm Johanna Duran. I'm the CEO of Triage Cancer, which is a national nonprofit organization that provides free education on all of the legal and practical issues that come up after a cancer diagnosis.
I'm Rich Sagal. I'm the president and one of the founders of Needy Meds. We're a national nonprofit that has information on programs that help people who can't afford medications and healthcare costs.
Great. Perfect. So we will get started then. So the challenge that this particular panel is really looking to kind of address or to kind of tackle this afternoon is that the symptoms and treatments of some illnesses and diseases are complex and multifaceted. Navigating the associated financial burden only adds to that complexity. And as we learned in the sessions this morning, one patient may need to access assistance from multiple manufacturer patient assistance programs and charitable patient assistance programs, which we learned they can, adding to the patient's burden and the burden of their caregivers. And no one program fits all patients managing a specific diagnosis. So that's the challenge that we're here. And our objective is to provide some insight into these types of challenges and complexities through patient journey examples, to discuss what manufacturers could consider when developing their assistance programs to be customer/user-friendly, discuss and identify other ways manufacturers could support and assist patients through advocacy or other avenues. And as a side note, I mentioned this earlier today for the charitable patient assistance program suggestions. I strongly suggest attending tomorrow's main stage presentation, which is, I got the official information. It's what's next in patient assistance and support, and that's tomorrow at 9:15 to let your ideas be heard. So the outline for the program or for the panel today is each of our panelists has selected a particular challenge, and we'll have 15 to 20 minutes to present that challenge using a patient story or a hypothetical patient case. And then we'll dig deeper into what could have made the patient's experience easier or their outcomes better. And finally, we will open it up, of course, to questions from the audience. So I'm going to have Rich come first. So, and again, Needy Meds is a national nonprofit that educates and empowers anyone seeking affordable healthcare, providing information on healthcare programs, offering direct assistance and facilitating programs. So, Rich, I'm going to invite you up to walk us through a hypothetical patient case and the different assistance programs they might access.
Thank you. I want to tell you just a little bit about Needy Meds. I consider it my passion. My wife considers it just an annoyance. But I love to talk about Needy Meds. I've been working on it for probably 27 years now. My background is family practice for 25 years, and this for about 27. We have information on close to 40,000 programs throughout the country. These programs provide various types of assistance. We do not provide the assistance, we provide the information. I like to say we are like the yellow pages, but that comparison is fading fast because too many people don't remember the yellow pages. But we have the information. Individuals have to use the information. We have data on over 20,000 free low-cost sliding scale clinics, almost 4,500 diagnosis-based assistance programs, over 4,000 coupons, copays, and rebates, over 1,200 state programs, over 2,100 what we call application assistance programs. These are programs that help people apply to programs, and a couple thousand camps, scholarships, and retreats based upon diagnosis. Now, I'm going to use a hypothetical situation because I don't deal with the callers directly any longer. But we have a young woman coming in to see an advocate, just felt a lump in her breast and is in a panic and doesn't know what to do. Now, what I'm going to do is ask you folks to come up with suggestions that you could help her find assistance, aid. What sort of programs would you recommend to her? I'll start off by saying the first step is to refer to one of the clinics that would be no charge since she has no insurance. Where would we go from there? If we get no volunteers, we're going to pick on people. What would be the next step that you would do? What sort of program would you refer her to? Well, we did that. We always sent her to a free low-cost sliding scale clinic. Well, we don't know what the diagnosis is.
So we need to confirm, we need some kind of release to maybe get some information from the doctor. Would be the next step then?
Well, the next step we refer to a place that does a screening mammogram. So that would be one thing you could do. What other suggestions do we have? What else would you do once you get the screening mammogram? Yes? That's a good idea. Let's assume that we can't. Medicaid would want to look for the treatment programs, and we list many treatment programs on the website, programs under the clinics that deal with this type of a problem. Now, let's suppose she's prescribed a medication. What would be the next step for that? An expensive medication that she has to take. How about a patient assistance program? There are we have 470 patient assistance programs listed. So that'd be one step. We could look into insurance, as someone mentioned, with co-payments. So we got her into treatment. She's not working. What sort of programs would you refer her to for that? How about cash grant programs? There's a surprisingly large number of programs that will give people cash for just living expenses. So she's in a treatment program, but it's a distance away. What programs would you refer to for that? Transportation programs. There are many organizations that will provide free or low-cost transportation. She has a car, but it needs repairs. These programs would help her with that. She also may need money for gas, and there are many programs that will give gas credit cards or debit cards just to use for gas. Another issue that might come up is her family. When she goes for treatment, what does she do with her children? Any thoughts?
Childcare.
Childcare. There are programs that will provide either cash for childcare or actual childcare costs. If she lives in a very rural area and there's no treatment, she may have to drive a distance. There are programs that provide housing when people travel. What other assistance might she need? You think of anything else? Food. There are programs that provide gift cards for grocery stores, provide food baskets. Some programs have pantries. So you could look and see if there's programs like that. How about medical equipment? She may need dressings, this sort of thing. There are programs that provide medical equipment. There's also programs that provide durable medical equipment. You probably wouldn't need any of that, but there are programs that provide that type of assistance. She's feeling down because of the program, or because of her diagnosis and what's going on. Mental health. There are a lot of mental health programs. With her children, there are child care programs, as I mentioned. Food pantries. How about her pets? She has a dog. What would you do about that? Well, there are programs if she has to be gone all day for treatment, they will walk the dog. Or if she can't handle it, there are programs that will foster the pet for a while. So, as we all know, pets are very important for people. People don't want to leave when a flood's coming because they can't take their dog with them. Many of the homeless won't go into shelters because they can't take their dogs with them. There are also programs that will help with pet care clinics free low-cost sliding scale animal clinics are around. Going back to food, there are meals at home programs that people can use. Now, if she's going in for treatment, she's concerned about losing her hair. Is there anything we can do about that? Before the wigs are you've lost the hair. Prevent the loss of hair, there's something called scalp cooling. Has anyone heard of that? What we know is that if you cool the scalp while getting chemo, it decreases the hair loss. And you put on, looks like a helmet, and they run cold water or dry ice they use, and then helps save hair. It's expensive, but there are a number of programs that help with scalp cooling. Now, if she loses her hair, as someone mentioned, there are programs that provide wigs. There's some programs that provide wig styling so they can make the wig look nice. There's other programs that provide turbans, scarves, hats. There are also programs that provide cosmetic makeovers. She has a surgery and she has some reconstruction, but she's not happy with the results. It doesn't look like a real breast. What can be done for that? Anything? There are programs that provide nipple tattooing, where specially trained tattoo artists will tattoo on it what looks like a nipple. They will also do nipple tattooing for eyebrows and scar reduction. And there are programs that will cover the cost of that. Now there's camps, scholarships, and retreats programs for people with cancer or their children. So they're around other kids whose parents are suffering from the same types of problems. And then there are programs that provide help with the cost of funeral expenses if the treatment is not successful. Now all these programs are listed on Needy Meds. Many of them are under what we call diagnosis-based assistance programs. We strive to have every program that's available. We know we'll never succeed because there's so many programs. But we do depend upon the help of the users who come to the website to help us with new programs that we might not know of. I learned of 2 programs just yesterday here that we did not have. So if you find any programs, particularly the local ones, it's easy to find the national and the statewide and the regional, but the small local ones are difficult to find. So if you know of any, please let us know. So check out Needy Meds. We're always making new programs, additions, updates. And the website that you see today is going to be changing within the next month or 2, trying to make it more user-friendly and also increasing the searching capabilities. So that's my spiel about Needy Meds.
Thank you. Great. Rich, I have a question for you. How do you all get your funding?
We get our funding in We get our funding a number of ways. I should mention that we never charge individuals for anything at all. The website is free to use. It's anonymous. There's no registration, sign up, or enrollment. So anybody can use it. As I said, we have a number of sources of income. We have some grants, some donations, never as many as we'd like. If anybody has an extra 5 or 10, I'll take it. We have a drug discount card that's saving people about $1 million a month that anybody can use. We license our information, so if somebody wishes to have all the free clinics on their website, we license that information. We work with some pharma companies and some medical equipment companies, helping them design, and we will run their patient assistance programs. So those are the main ways that we cover our costs.
Okay, great, thanks. So, and I appreciate all of Rich and the work that he's done creating Needy Meds, and the number of resources that are available to patients is actually pretty impressive. And I think it's important to try and get the word out and to tie it back to kind of what we're looking for from the manufacturer's perspective. Again, it's kind of that, it's the balancing, right? It's that creative budgeting. So the more manufacturers can put into their own programs, that helps when the other programs aren't there or unable to be identified. I think it's a great message to kind of pull back that talking about these programs is really important. I would love manufacturers to, look at programs like Need Meds and promote them as well, in addition to their own programs. Wouldn't it be great to have a Needy Meds commercial, you know? And I think too, just to drive to basically drive the exposure to the program would be really, really helpful. So next up, we're going to have Joanna. Triage Cancer provides free education on the legal and practical issues that may impact individuals diagnosed with cancer and their caregivers. And your vision is a world where everyone has access to information and resources needed to find their best path forward. During our planning sessions, you shared a significant challenge, especially in the cancer space, as care denial and complete lack of transparency in the appeals process and the extent to which providers can pursue appeals. So I'll invite you up to share your patient story.
Thank you. So at Triage Cancer, we hear a lot about the challenges of financial toxicity. And I think that that is something that the cancer community spends a lot of time talking about, but it certainly blends over into other types of serious medical conditions. Having a health condition is a financial burden. And one of the challenges that we see with financial toxicity is that people don't have adequate health insurance coverage. We think that's the biggest contributor to financial toxicity. People might have insurance, but they are underinsured. They have exceptionally high out-of-pocket costs. And when we talk about the challenges of navigating health insurance in the United States, it's because no one understands health insurance in the United States. So, it used to just be our anecdotal opinion of that, but there's plenty of data that shows that no one understands health insurance in the United States. And health insurance and healthcare literacy are significantly low. And so then how do we expect people to effectively navigate systems or make choices that are adequate for their health insurance coverage? But even though we think that's the biggest contributor to financial toxicity, it's still only the first step. The second step is understanding how to use your health insurance once you have it. And where we see the biggest challenge with using insurance is not understanding insurance company rules, like accessing prior authorizations before getting access to care, but also insurance companies say no. So how many of you actually attended the earlier session on appeals? Anyone? So when we're talking about the appeals process, it's literally our right to not take no for an answer. Insurance companies say no, they're not going to cover something, and we have the right to question that decision. And we get that right from the law, and understanding the process on how to actually access those protections is easier said than done, because the appeals process is very dependent on the type of insurance coverage that you have. But I want to take the example of private insurance specifically and talk about that for a minute. That's individual health insurance coverage like a marketplace plan or an employer-sponsored plan. There is a federal law that requires insurance companies to provide an internal appeals process. So you get to go back to the insurance company and say, I disagree, I'd like you to reconsider. But if that insurance company says no, you have the right to go outside the insurance company to an independent entity and ask them, should the insurance company have covered my care? And that process is called independent medical review or external medical review or the external appeals process. I think that this is the best kept secret of our healthcare system. Because when I say no one uses it, I mean no one. We don't have a lot of good data on the appeals process and the number of claims denials across all types of insurance plans in the United States because no one requires them to provide it, except specifically for marketplace plans, because the Affordable Care Act required those plans to report out their denials and their rates of appeals. And for those marketplace plans in 2021, 99.9% of those denials were not appealed to even the first level of appeals. So that when I say no one uses the appeals process, I mean no one, 99.9% of people based on the data. And so if only 0.1% of people are appealing denials, that means two things are happening. They're either not getting the care that was prescribed by their healthcare team, or they're paying for it out of pocket. And so when we talk about what's contributing to financial burden, if patients are paying for their care out of pocket when the insurance company should have been paying for it, that's contributing to financial burden. And so I actually want to tell you a story that I actually read in a newspaper. And it was the story of how a doctor was advocating for her patient. And this doctor, I won't tell you where it was or the type of medical condition, but this doctor was advocating for a patient to get a type of treatment. And this patient had already tried many other lines of treatment before that. And this was the end of the road. This was the last option available to this patient. And the insurance company denied coverage for that treatment. And the doctor went to bat for the patient. She advocated. She filed the internal appeal, went through the whole process with the insurance company. The insurance company said no. The doctor said, well, give me a peer review. And a peer review is when the doctor from the insurance company and the patient's doctor actually talk to each other, which, you know, in this healthcare system seems amazing that two people will actually talk to each other. But that's what a peer review is. And when the doctor talked to the patient's doctor, the doctor said no. And so ultimately, even though they got to the peer review stage of that process and how hard the doctor advocated for that patient's care, the insurance company still said no. And that patient didn't get access to that treatment, and that patient died. What was missing from that process? There was no external appeal filed. So even where a doctor thought that she was doing everything she possibly could to help the patient access that care, she didn't know about the external appeal process. And to me, that's a tragedy that a patient died because she couldn't get access to the care that her insurance company denied, even though her healthcare team said it was the most important thing for her to be able to stay alive. And so when we talk about accessing insurance and asking for financial assistance and all of these pieces, at the end of the day, we can't forget it's about patients' lives. And so ultimately, that lack of knowledge of the appeals process isn't just about financial burden. It's about saving patients' lives. And there's so much opportunity to improve knowledge of that process beyond just saying, if an insurance company isn't going to cover the care, let's figure out how we can get the patient financial assistance to get access to that care. Let's first make sure we exhaust all of the processes that exist to make sure the patient can get access to that care. And then that patient is still going to have out-of-pocket costs. There's still going to be transportation and childcare and so many other needs that are going to be there. And so we want to make sure that we're maximizing the coverage so that the patient can tap into all of that other financial assistance. And that only improves the amount of financial assistance that there is to go around for patients to help with all of the other things that insurance doesn't cover. And so if you can't tell, this is a soapbox issue for ours at Triage Cancer because it is unjust and unfair and ultimately has the ability to save patients' lives. But we also know that that lack of knowledge is widespread. So it's not just patients and caregivers who don't know about their ability to appeal denials, it's the whole system. So if providers don't know either, that's contributing to the problem. And so we want everybody to know about the appeals process so that everywhere along the care continuum, whether it's access to screening and diagnosis, to treatment, to survivorship issues and long-term and late-term side effects, that there are opportunities to tap into that appeals process and to make sure that it's being utilized to get patients access to care and mitigate that financial burden. So I will step off my soapbox now.
Great. Thanks, Joanna. I actually have a question for you. It dawned on me. Is there any repercussions if a patient is denied and then they figure out a way to start treatment anyway? Like, can they still appeal? Like, there's no like, oh, well, you figured out a way how to get it, and so now
there are deadlines for filing internal and external appeals. There are also deadlines for insurance companies to respond to those appeals. But even if a patient has said, and this comes up a lot in the context of cancer, where it's time sensitive that a patient get access to treatment. So a patient can start treatment and then file the appeal and then get reimbursed for any care they've paid for out of pocket.
Okay. Thank you.
The appeal goes their way.
Yeah, it dawned on me. I was like, I wonder if there's any, loophole that, they figured out how to start the therapy, so now the appeal stands. No. Okay. Perfect. All right. Thank you. I appreciate that. So next up is Susanna. Community Liver Alliance promotes liver disease awareness, prevention, education, advocacy, and research by investing in local communities and giving voice to patients and providers. And Susanna, I read on your website, and I love this, that CLA meets people where they are. And I think that's the crux of advocacy, is you meet patients where they are and you walk with them moving forward. I just love that. So I just had to throw that in there. But you do that using proven practical and public health strategies to remove barriers, increasing educational opportunities, expanding health access, and treating people with love, respect, and dignity. Has and will continue to help eliminate health disparities, including all forms of liver cancer. So I will invite you up here to share your patient story, and then we will continue on with our panel. Thank you.
Thank you for inviting me to present today. I feel honored to be here among my colleagues. And so the Community Liver Alliance, through our mission, supports the liver community, but we're also able to support the broader community through our advocacy. And we reimagined our strategic plan when the pandemic began. We realized that we needed to remain relevant and responsive in our liver space. And how could we do that? So we know that through our strategic plan, the overarching opportunity for us and our goal is to affect health equity and justice for vulnerable communities in all we do. And so health disparities are inequitable and are directly related to historical and current unequal distribution of social, political, economic, and environmental resources. And inequities in health outcomes result from inequities in distribution of or access to resources that promote good health outcomes. And that's also including health insurance resources and support. And we know that these health disparities became more apparent during the pandemic, right? And we feel empowered to address health disparities, including differences that occur by gender, race and ethnicity, education or income, disability, or geographic location, or even sexual orientation. And these health disparities, they affect people with liver diseases, but they affect a lot of people. And liver disease, it's more than just an organ or a disease. It's a whole person, right? And so we look at the whole person. And, through our advocacy, we want to provide a voice for not just the liver community, but the larger, broader community, particularly vulnerable populations. And so it's more than just access to health care. It's about social determinants of health too, right? These inequities are more, and we heard about this through some of the stories that my colleagues have shared. And I did update some stats, and I wanted to share those with you before I share my story. And Black populations receive worse care than white populations for 43% of quality measures. American Indian or Alaskan Native populations receive worse care for 40% of quality measures. Hispanic populations, it's 36%. Asian and Native Hawaiian Pacific Islander populations, it's 30% of quality measures. And we think about people in poor households. It's not just about ethnicity or race, but it's also about income. And poor households had worse access to care than people in high-income households for 79% of access measures. That's staggering. And maternal and child health care, we think about vulnerable moms and their babies, and poverty has a strong link to poor reproductive outcomes, both in combination with exposure to discrimination and among low income and racial and ethnic minority groups are particularly vulnerable. And yet, our country has one of the highest rates of poverty in the developed world, despite its collective wealth. It's just staggering. And when you think about, research that happens in our communities, there's some research that happened here at Tulane University, and it revealed that in 2018, racial and ethnic disparities cost the United States economy $451 billion, a 41% increase from the previous estimate in 2014. I mean, it's just unbelievable. And at the Community Liver Alliance, and I think around this room, we believe it's the right for all of our citizens to have access to affordable, comprehensive health care. But unfortunately, there are many barriers, and especially for vulnerable communities. So I want to tell you about Jose. And Jose has a family. He works 2 jobs. He is underinsured, like most folks in his community. And he went to the community clinic because he was experiencing some issues with his health. And he was diagnosed with fatty liver disease. And his community doctor said, well, you have fatty liver disease, but it'll be okay. You just have to lose some weight. Okay, so Jose went home and lost some weight, and he lived happily ever after. That's the good story you asked me to tell, right? Everything was great. But unfortunately, what happened to Jose is that he listened to his doctor, because we all listen to our doctors, right? And they are like God. And so he didn't worry about his fatty liver disease, and he did lose some weight, and he experienced more symptoms of his liver disease. He was very sick, and he went back to the doctor, and the doctor said, well, you'll be okay. You just need to continue eating well and lose your weight. Well, he ended up in the emergency room. You have to remember, all of these are considerations that he would get more sick because he couldn't afford it. His insurance wasn't enough. His copays were high, and he couldn't afford to take care of his health when he had children and a wife. So he goes to the emergency room in his community health center, but they're not equipped to help him. So they have to, by ambulance, transport him to an academic center where he's diagnosed with late-stage cirrhosis, liver disease, and needs to be listed for a transplant. That would be a situation that would help Jose. But unfortunately for Jose and his family, they did not have the resources to embark on a liver transplant. Although they tried, he became more sick, and then he was unable to receive a transplant. You have to have certain criteria to receive a transplant, and they're hard to get, right? I mean, many people need them, and few people get them. And so, unfortunately, Jose, he died. It was unnecessary. And it had a lot to do with his access to care, about his stature in the community and life. What, not just insurance companies think about people who are marginalized, but also what health systems think about people who are marginalized. And I think some of the solutions might involve stakeholders. They should involve stakeholders from across diverse sectors, including community and faith-based organizations, businesses, manufacturers, surely. When you're thinking about innovation, you're thinking about the investment that you're making to help people, and you have these great resources, but we need to come together and have conversations. Education sector and academia, philanthropy to fund this, right? And thinking about housing and justice. And again, we talk about social determinants of health and how they butt up against the disparities that exist for people in vulnerable communities. And the medical community and related stakeholders should adopt strategies and approaches to address the financial and related public policy issues. And I forgot to mention policymakers. They're a huge part of this. What we're doing isn't working, and it's not enough. And we look at our low social economic status communities and minoritized communities and immigrant communities and refugee communities. And we know it's a major challenge for the broader medical community to, reconceptualize, think about how can we do things different? Because what we're doing isn't working and it's costing us money. It's costing us lives. So I think there are ways, but one of our mantras at the Community Liver Alliance is that we're stronger together. And we believe there are ways to affect health equity, racial justice, equity for people with disabilities if we just come together and, work on this situation and insist that people come together and hold them accountable. That's my story. Great. Thank you.
So I appreciate that, through some patient stories, we've kind of covered a little bit about financial toxicity, the complexity of appealing care denials, and the devastation of health disparities can wreak on patients. So I have a couple questions for the group, and then we definitely have time to open it to the audience. So in your stories, where in the journey would you add a crossroad that would have led to a better, a different and wholly better outcome? And what would that option have been? So like if you could just insert one little place where it's like, okay, now you're at a crossroads. The one path was this way, but they had something and it just put them on a different pathway to a different outcome.
Well, I want to talk about the appeals. One thing that wasn't mentioned is physicians are never taught how to do an appeal. And when I was in practice, I had to do some of these. And one of the things that I made a point of doing was recording in the medical record everyone I spoke to. And I would tell them that I'm going to I just want to get your name right, your phone number, and your job description so I can put it in the medical record. And very often the first to second level person with the appeal said, you can't do that. And I said, you watch, I am. Speaking to the physician, I had to speak to a number of physician reviewers. As soon as I got him on the line, I would do the whole case history of the patient. Then I would stop and say, now, doctor, what would you do? And put them on the spot and record that in the medical record. And it's important to put in the medical record because if there's any suits later on, their participation becomes public knowledge, and they don't want that to happen. So I think that you need to teach physicians how to do appeals.
That's good. Yeah.
I wholly agree. I think that was my point. I think that everybody needs to know how to do the appeal because it might not be the physician who's helping. It might be someone else on the healthcare team who is actually the one filling out the paperwork and making sure that all the T's get crossed and the I's get dotted and the deadlines are met and that the correct information from the medical record is getting included to support the medical necessity of the treatment. And so I think that that's part of the problem is it's completely a lack of knowledge. And so there's a whole lot of opportunity to provide education. And I think that that's to your question about the crossroads. I think if the provider had known, if somebody on the healthcare team had known about the availability of external appeals, there would have been a different outcome.
So we live in a world where they don't know right now.
Exactly.
So how do we get the word out?
Well, we certainly try to do our part at Triage Cancer. We have an endless number of resources to help people through the appeals process across all types of insurance. So we have a resource called cancerfinances.org, which covers education on all the topics that can impact finances, but there's an entire module on appeals. And the first question is, what type of insurance do you have? And then it walks people through the process. But we also train healthcare professionals. We provide free trainings for healthcare professionals to get actually free continuing education to actually learn about how to help patients better navigate the systems, including appeals.
Right.
So for us, it's just about spreading the word. I will actually, if you'll let me, just mention one other thing, that we provide education at Triage Cancer that is not cancer specific. The education is applicable to anybody, even before you're diagnosed with a serious medical condition. And so we get asked to speak a lot on topics outside of the cancer community. And so we rolled out a program this summer called Triage Health, which provides a lot of this education that doesn't say cancer, to improve people's awareness that it's available and that they aren't kind of turned off by the idea that it says cancer or that it doesn't apply to them.
That's excellent. And also, I think conversely, we put a lot of onus on the provider, which we agree. The Community Liver Alliance is developing toolkits for primary care to better understand common liver diseases and to diagnose them and to destigmatize. There's a lot of stigma around liver disease, right? When you hear liver disease, you think of what? Drinking, right? Something you've done to yourself, and it's not a lifestyle disease. There's more than 100 liver diseases, and we're a patient advocacy organization, so we spend a lot of time educating patients to be better self-advocates, to understand, and to be a resource to them. And now that I know about your organization, I know about Needy Meds, but I'm definitely going to add you to our resource list. So I think savvy patient advocates can also help at that crossroads.
Great. So, and I guess I know our next question was kind of why wasn't it an option for a patient? I think we know that because there's an education, there's some challenges, there's stigma. So to problem solve a little bit, what could we do? You talked a little bit about toolkits and, educational pieces. I remember back in the day, when I was still working on reimbursement side of things, manufacturers would try and help with the appeals process. And Erin, can they still do that or is that change? Yeah. Yeah.
There's just a very limited amount that the manufacturers can put their hands on.
Correct.
So it's like they can have like a template letter. Usually it's their hub. Usually it's the manufacturer's hub.
Mhm.
But still it's an agent of the manufacturer.
Correct.
Very, very limited appeals support that they can do under the current system.
Yeah.
But I think that there is one opportunity there where the companies can say to a patient who is asking for help or a provider who's asking for help, pursue the appeals process. And here is what we can provide. And, these are some other things that you should go look for on your own. Like the medical evidence for why a particular treatment is appropriate for a particular type of medical condition. And so it is just connecting people to even know it's available. And so that's, I think.
Yeah. Or even to just say, hint, hint, external review. Don't forget to ask. Little card. Susanna, did you have any comments? Or
One more thought. When you're going to get a physician, particularly one in private practice, involved in an appeals process, make it as easy as possible for the physician. Give them all the history, even write a first draft of the appeal letter, whatever you can do to make it easy for the physician to do, because their time is limited and they're not going to spend a lot of time on this unless you bug them.
Insurance companies, payers, can you hear me?
Yeah, you're on.
Put up a lot of roadblocks.
Mhm.
And I hear this from patients I've experienced myself. I've seen family members and friends go through this. And I think that people could be more, it could be more helpful through the appeals process when you're calling an insurance company a provider. They're not talking to the same kind of provider. They might be speaking to a retired ophthalmologist who can't even pronounce the medication or the treatment. So all things aren't equal. It's not fair. And there are so many barriers to patient care, not just the cost or the social determinants of health, but it's also just a lack of empathy. It's about making money. We think about non-medical switching, about PBM reform, and many other barriers to patient access. So I think it's a bigger ball of wax that we are thinking about.
Yeah. Okay. And speaking of financial toxicity, well, we don't have, I don't think we're going to come to some finite answers today, but what are some, no holds barred, right, solutions to fixing the problem of financial toxicity? I can actually ask the audience as well.
I think policy changes. There has to be policy changes. We, the Community Liver Alliance, we're situated in Pittsburgh, Pennsylvania, and we lead a non-medical switching coalition. Non-medical switching is when an insurance company changes your benefits mid-year for non-medical reasons, primarily financial reasons, to save themselves a nickel, right? And so patients suffer because of this. We have testified, we have legislation in both the House and the Senate. We help other states with their legislation. And I think that it's about educating policymakers and holding them accountable, not just in the state, but that's where you can make an immediate impact. But we absolutely have to have reform on a federal level as well, because there's too much power over people's lives, not just health, but their lives, as we've heard described. So I think, coming together in a coalition with many stakeholders, but again, meeting people where they are means centering the voice of those people, that patient, those communities, and they should be the center of it. It shouldn't be without them. Nothing about us without us is the mantra.
Oh, I like that. Like that. Rich.
I think we also need to educate people about insurance and how it works. I like to tell people there's no such thing as a free lunch. It's all a matter of cost shifting. If you want to have better insurance coverage, someone has to pay for it. It doesn't come for free. I also remind people that you want to remember that with insurance, you never win. Either you spend all this money and get very little out of it because you stay healthy, or you get sick. So you don't win with insurance. But people think I have insurance, it's going to cover everything. No one has to worry about the cost. And it just doesn't work that way.
Great. So what about some ideas on how we could work together? And Suzanne, you said coalition. What are some other maybe more localized, this community in the summit, like how can we work together to kind of, affect change? Well, I will say we're going to have the exhibit hall open this afternoon. And there's going to be, there's a lot of different groups down there that can, and again, I think the purpose of the summit is to really kind of build tools for, toolkits for our advocates. So I would encourage, visit all the booths, collect all the information, scan codes, ask how I can get information to kind of help me build my toolbox when I go back and I'm sitting with patient one on the next day I'm back in the office. What are some tools that I can grab? What are some new things that I've learned? I did not realize that there was an external, appeals process. I always thought it was like you kind of ask once, maybe twice, but this is like, that's kind of like it's going outside of the insurance company, which is different, and it's going to have not the same. The impetus is to save the insurance money. Well, now you're not working with the insurance, it's someone else's decision. And I think that I actually did not know that was an option.
I think that's really the heart of the challenge. As advocates, we all work really hard to create policy change and to do things to improve our healthcare system. But if we spend all that time focused on just getting those advocacy efforts accomplished, and then we don't tell anyone about them,
right,
or tell people how to access them, then what was the point? And that this external appeals process is just one really excellent example of that problem, where we fought as advocates to get that independent review, and then no one knows it exists. Not the providers, not the patients, not the caregivers. So if no one knows it exists, then why did we bother? And so I think that is the same. Anytime we're engaging in policy change, we also have to bring the education with it. And I think that is an incredible opportunity for partnership across all healthcare communities to make sure that all patient constituencies and the providers really understand where those opportunities lie to improve patient outcomes.
Absolutely. I echo that. And the grassroots efforts is very important. Op-eds, there's a lot of free ways to educate people, and it's, one person at a time, and it's also one organization at a time. I think bringing all of these folks together in forums like this really does make an impact and helps us to brainstorm and to think about how we can work better together and what other resources are out there.
Great. Absolutely. So at this point, I'd like to turn it over to the audience if there's questions. And we have to wait for the mic, I know.
Yeah, and if we could use the mic just so that we can make sure that the live stream can get your questions as well, and not just your answers.
Great panel. Thank you. So the current administration actually is trying to figure out things in both the cancer space and on the liver space with the Cancer Moonshot, and also with Francis Collins heading up the hepatitis C issues that only 1/3 of hepatitis C patients are actually getting the therapy that is out there. Is there anything that can be done, given that there's some national attention being paid to both spaces right now, in terms of getting the policy to be a little bit more patient friendly so people can be put on the therapies that they're supposed to be to make cancer a chronic disease rather than a life sentence kind of thing, and also making sure that people who have hepatitis C, for example, are actually getting on the amazing therapies that are actually being curative at this point?
Sure. That's a really good question, and there is a national effort for hepatitis C elimination. There are several coalitions that have come together to address that and to center the patient voice. And for those of you who might not know, there is a cure for hepatitis C. I mean, when is the last time we had a cure for anything in our lifetime, right? This is something very exciting. The manufacturers figured it out and brought down the prices. It's affordable. And so it's hopeful. And, bringing people together, having conversations. The CLA sits on two coalitions, one with the American Association for the Study of Liver Disease, and the other one for NASTAD, to have conversations. And we also had a National Viral Hepatitis Summit in Pittsburgh in July and brought together Dr. Florence, who works for Dr. Francis, to talk about it, the CDC, and all of the national and local and statewide organizations to really come together and think about. And we had panels for people with lived experience to share their feedback, to tell us what they think, because we can't do it without them.
Another thing is vote for the right people.
I think I would just add around the moonshot and the focus on improving treatment options and even screening and detection options and biomarker testing, is that we can, it's the same thing, right? We can advocate for increased research funding and focus to create these new treatments, but if people can't access them, what's the point? And so making sure that the barriers to access are eliminated is, in my mind, pretty key in partnership with focusing on creating all of those new options, is making sure there's the access. And I think that there's a whole lot of room for improvement in our healthcare system on improving access. And appeals is just one example.
Hey, Joanna, I had a few. Hi, Erin.
I feel like we should meet.
Erin here. So, two questions about the external appeals, because this is fascinating to me. My first question, being a little bit of a cynical healthcare regulatory attorney, is who is the external appeal organization? Like, are they just an arm of a plan somewhere? Like, are they truly independent?
That's a good question. And the answer is it depends. So lawyer to lawyer, that's my lawyer answer. In It depends sometimes on the type of plan. So if you're talking about an insured, like an employer's insured plan versus a self-insured plan, the self-insured plans get more leeway under the law to pick their independent review organization. So if they get to pick it, that review organization almost by definition has an internal conflict. That was the point of external review, is to remove that conflict. Not to say that they all act in a way that creates a conflict, but it is there. If you have an individual plan, like a marketplace plan or an employer insured plan, then it is an independent entity and it's regulated in most cases either by the state insurance agency or HHS.
That's awesome. And then the second question is, does that external appeal right have any loopholes or exclusions? I'm always thinking about, it's for everybody except this group.
The only loophole, so to speak, that I see is in the self-insured plans and their ability to pick their independent review organization. I think that it is one of those systems that actually works pretty well. So what I didn't share is that on average, 50% of the time since this has been in effect across the country, patients win. So when you think about 99% of patients don't even get to the first level of appeal, but if they got to external appeal, 50% would win. That's pretty substantial. And so I think that the biggest loophole is in the way that insurance companies actually tell you about appeals. It's like usually on the back side of the denial letter in like tiny print or like super light font, so you don't even like pay attention to it. So, I mean, there are rules that they have to provide notice of your appeals rights. And some insurance companies do it well and some don't.
If you use that third party appeal process, do you waive your right to be able to litigate, or is it one or the other, or?
You don't. Your ability to litigate, though. So most insurance companies in their contracts have like arbitration clauses. So it gets into the very contract specifics of each insurance company. But when we're talking about ERISA plans, that are governed by ERISA, like those self-insured employer plans, that a lawsuit really is the last resort. And the thing about those lawsuits is that you can't recover punitive damages. You only get compensatory damages. So you're only getting the cost of the service that you were denied.
Right.
So if you were denied a mammogram, for example, and you are diagnosed with late stage breast cancer because you couldn't ever get access to the mammogram, and I'm just throwing out an example, then all you get from the insurance company is the cost of the mammogram.
Right.
So there's no deterrent for the insurance company to deny the care. Because in a worst case scenario, they're paying for the care that they would have had to pay for originally.
I just have a comment on my to-do list of tasks that we're doing immediately. Action steps after this is I'm going on an independent campaign to make external review the priority for everyone. So if anybody wants to join me, there you go.
We're on board.
You're going to get a drum and just beat it. External review, external review.
So you're joining my drum circle.
Any additional questions? Yeah.
First of all, I want to comment on Rich's comment on how he personally handled appeals and putting the onus on that medical reviewer who doesn't normally have to see patients to put them in the seat of, you have to decide on a care that will work. What are you going to do? Because that's not a seat that they're in. I'm going to share that idea with the providers I work with. But in the subject of appeals, and the external review, I have found one category that doesn't allow external review, and that is if it's an administrative denial, such as a non-formulary, non-covered service under the terms of the plan, then that can't be argued medically. Are you aware of any alternates that are similar to an external review that would qualify?
I can't think of another example, but I will say that just because an insurance company says it's not covered isn't a reason not to appeal. So I'm going to give you an example. So that comes up a lot in the cancer community context, and it's around fertility preservation. So most insurance companies say fertility preservation is not a covered benefit. However, in the cancer community, there's a whole lot of medical evidence that shows it's medically necessary in order for a patient to retain their ability to have biological children in the future, because of the cancer treatment that they're going to have is going to have an impact on their fertility, iatrogenic infertility. So there's evidence of that medical necessity. And so if the insurance company is saying it's not a covered benefit, but there's an argument for medical necessity, it doesn't mean by definition that the insurance company doesn't have to pay for it. Otherwise, insurance companies would say everything's not a covered benefit, right? So the idea is you would go outside the insurance company to an independent entity to say, is this medically necessary or not? Even though the insurance company is saying it's not a covered benefit. And we use that fertility preservation example a lot to explain to people the importance of filing an internal and external appeal at the same time as an expedited appeal so that they get a response back within 72 hours. So because there is a time sensitivity to getting fertility preservation before you get cancer treatment. And so it delays getting access to the cancer treatment if you delay the ability to get fertility preservation. So I don't know if I answered your question exactly, but I want to just make sure that people aren't dissuaded by filing an appeal just because an insurance company says it's not a covered benefit.
Thank you.
Yes. It's kind of like when I was doing my opening remarks, I said, we have to talk and we have to ask. So we have to talk about the issues and we have to ask questions about it. So it's kind of along the same line, like you should ask, I would like to pursue an external review. Well, it's not a covered, well, I would still like to do that. So, to kind of push that envelope, and ask the question and push those envelopes, especially when it's to the benefit of the patient.
And it never hurts to ask.
Right.
Just to highlight that point, I used to work with the state insurance company that handled the health benefits for state employees. And, it was shocking to me where you would go into these rooms, the analytical effort certain members of this committee at the initial review stage would take to put you into one of the loopholes that exclude you from coverage. I mean, so what they call, not covered you'd be shocked at some of the things, the efforts they would go to deny coverage. It was shocking. So don't just accept it.
I can't imagine being shocked at this point. But I will say we didn't even bring up AI and how insurance companies are using AI to make these decisions. And so, we're paying close attention to see how this evolves. And companies are being, called out for it now. And I think that there's an opportunity for policy around ensuring that companies are complying with the laws that already exist, and then opportunities for the advocacy community to continue to make sure that there aren't loopholes in the way these laws are actually being implemented.
Right. I think there was an article recently where it was a Medicare Part C, where it was an AI kind of an algorithm behind the scenes. And it was kind of like, if you remember the DRGs when they first got rolled out. And it was kind of a throw forward to that, where the AI is saying what we've seen historically is that a Medicare patient comes in for this, and they have this many days in the hospital, and then they should go to rehab, and then they have that many days in rehab, and then they got to go home. which we know that each patient is completely different than the next one, and you have comorbidities rolled in there. But yeah, like, I don't remember. I don't know if my team remembers the article that I think Linda sent out, but I'll have to pull it. But it was scary. I mean, I'm reading this. I'm like, dang, my parents have Medicare Part C, and like, my mom has AFib, so she goes in for anything. That's something that's going to impact how long she's going to need to be in the hospital before she can go to a rehab center or even go home. It's a little scary,
There's also really good data on Medicare Advantage plans and the denial rates, but that if patients actually appeal the denials, they're successful a large percentage of the time.
Yeah. So appeal. Great. Any other figure? Yeah, about 15 minutes left. Any questions? Any additional questions? Yeah, there's one in the back.
Hello. Thank you guys for being here and providing all this great information. I'm new to the advocacy space. Previously, I'm a oncology nurse for 15 years, so new in this space though. Are there any tips or tricks to writing a good appeal letter or verbiage that you use in a way to present your case to the insurance company in order to, ensure that your patient is getting coverage?
Well, I think that you want to have all the history that's relevant. I know my wife is a migraine sufferer, and with 2 different insurance companies, we had to go through the appeal process to get the medicine she needed. And because I'm a physician, I knew what to say, and went through the whole history and why she needed this expensive medicine that was not covered, and we won both times. So you want to give all the history. Make it as easy as possible for the reviewer to see your side.
I would just add that I would echo that and say that the legal standard is medical necessity. So all the information has to be focused around why it's medically necessary someone get access to particular care. And if that means the medical records, an additional note from the healthcare team to explain a patient statement themselves about what they're experiencing, especially when they're having side effects and it's a medication to address side effects, even how it's about impacting their ability to work or, activities of daily living. I would also say if there's medical journals or scientific literature that reinforces why a particular treatment, they often will claim something's experimental or investigational if it's new. If something's off label, but it's the only treatment available to a patient, why is that something that, the healthcare community is seeing as a potential treatment for this new condition? So any sort of medical evidence that is going to back up why an insurance company should pay for it.
You want to include if this has been a successful treatment in the past and how it's affecting one's life. And you don't want to minimize. I had to convince my wife over and over, no, it affects you a lot more than you're saying. And I think that makes a big difference if you can personalize it and maximize the impact.
And on a personal note, I've seen this within my own family. My stepmother, she was able to write an appeals process for herself in order to continue to get care at the main campus of a larger academic institution. Her insurance was trying to push her to a regional, and she had had an unfortunate misdiagnosis. And so I just thought that was encouraging that as a patient, she was able to advocate and appeal for herself to continue to get treatment where she had been. So never be afraid to ask.
Because the answer is always no if you don't.
So how do we encourage, because there's the process side of it, but I can sense that there's probably patients out there that are like, no, I don't want to bug. I don't want to be a problem. It could be generational. I don't know. But, is there an educational piece to the patients to say, no, it's okay to stand up for yourself. It's okay to ask questions and say, I need fill in the blank and push that. How do we convince them that it's okay to do that?
I would say everything that we teach at Triage Cancer is about self-advocacy. So making sure that you know your rights at work and understand your insurance and know your ability to apply for disability. And along the way, in all of those systems, people are going to say no. And preparing people that they're going to hear no and what to do in response, I think is actually really useful. Patients say all the time, well, oh, I don't want to ask my employer for an accommodation because I don't want to ask for any more favors. Well, it's not a favor. Your employer is legally required to provide that to you. But it's about getting past the idea that someone's asking for a favor and that they're getting access to what they're entitled to, and that they can be prepared for that no answer, and how to respond to it is actually, I think, the way to get people to feel comfortable that like everybody's saying no, like everybody is hearing no, you're not the only one, and here's what you do.
And also, I think to echo is caregivers. Caregivers are really important advocates for patients when they don't feel well enough, or, they don't want to be the bad cop. Have the caregiver be a part of that. I saw my sister, as my mother's caregiver, had a binder and was a great advocate. And so I think many people would do that for the people they care about. So educating caregivers and empowering caregivers is very important.
Sometimes just trying again at the same level works. I know with the patient assistance programs, we always tell callers if they say no, hang up and call back, and you're probably going to get somebody else who may be having a better day, and they may approve it.
If you at first, you don't succeed.
Yeah, try again, right?
That's right.
Yeah. Perfect. Any other questions, comments? Yeah.
So just a word about self-advocacy, because I think it's really important to remind ourselves as advocates that when a patient has just been informed that they have stage whatever cancer, there's a lot going on there. And it's easy to say you need to be a self-advocate, but right now there's a whole host of things that are far more important on Maslow's hierarchy of needs than being an advocate when it comes to being on the phone for hours and writing up some kind of, complex set of arguments for why you should get something. I think it's really important to be able to, capitalize on caregivers' presence, and the caregiver's probably in a better mental space to be able to do that. But as Suzanne always says, better to get whatever. How is it?
Plead ignorance and beg forgiveness.
Always plead ignorance and beg forgiveness. But
Auntie Susan.
Susanna says many things. We're going to make a book about all these things. But everybody in the advocacy community working together is really important to not just throw it all on the patient and say, you need to lead this effort, because the patient's not really going to be able to do that.
I love that you said that. And I think that when we talk about self-advocacy, one of the things that we actually teach people is how to ask for help and know who your resources are. So whether it's caregivers or organizations who can provide that support, or members of the healthcare team like social workers or navigators or financial counselors, but I think that knowing that you can advocate for yourself is actually step one, because if you don't know that there's something to ask for, you won't ask for that help. And then being okay with actually asking for help.
Any other questions or comments in the audience?
You bring up such a great point about just, we do a lot of patient education as an organization. One of the things we find is that, the old adage, where there's a will, there's a way. One of the problems that we've run into all the time is that because people are being told no so much, the caregiver exhaustion is real, the patient exhaustion is real. And I think a lot of times that where there's a will and they're told no, they lose their will. And so they don't have a way. And so I just love, really the theme of this whole, really conference, but especially this session has just been, we got to stay energized, and we got to keep all of these relationships in front of us. I think the relationships are more important than the resources because the relationships are the resources. So I just think, it's so important. I just love the conversation. Love getting to know each and every person I've gotten to meet, and also just hear these stories, because I think it's inspired me to get back out there and go and say, okay, I got to help people, be inspired to find the will again, because that's the part that the battlefield really lies on. And if we can inspire people to get energized again and help them just pick that will back up, there is a way. It's just, you just got to keep on keeping on.
It's actually also why I like the data around appeals, because it's easy to say like, oh, go appeal. Like, go fill out all the paperwork, go track down your healthcare team, go get the letter from your doctor, go get copies of your medical records. Like that, just saying that, I know is exhausting. But knowing that your chances of success makes it worth it, it gives you the will to actually go pursue all those things because you actually have a chance. If the data was worse, like if only 10% of appeals were successful, maybe it wouldn't be worth someone's time. And not every patient can advocate for themselves, and not every patient has a support network to tap into. And so it's a question about like, what am I going to spend my energy on? And so that's why I think the data sometimes around appeals, for me, makes it feel worthwhile. And I think patients respond that way too.
Any other questions or comments? All right. Well, we'll wrap up a few minutes early, and I think the next panel is at 3. Yes. All right. Thank you so much. Thank you for our panel. Thank you.